Low back pain. Patient is a 77-year-old retired sales clerk. Patient's condition started in 2019 when she was bending forward excessively while sweeping the floor and suddenly felt a localized, aching pain on the right lower back area, rated as 6/10 on NPRS. Patient also stated the condition worsens when walking and standing for a prolonged period of time. Patient disregarded the pain, assuming it was due to old age, and decided to sit down in a chair with low back support to rest. And while sitting down, she noticed relief of pain in the right lower back.
Taking the patient's vital signs. The equipment used is the sphygmomanometer, stethoscope, a watch, pulse oximeter, and a thermometer. To begin blood pressure measurement, use a properly sized blood pressure cuff. Wrap the cuff around the upper arm with the cuff's lower edge 1 inch above the antecubital fossa. Lightly press the stethoscope's bell over the brachial artery just below the cuff's edge. Then rapidly inflate the cuff to 180 mmHg or millimeters of mercury. Release the air from the cuff at a moderate rate. Then listen with the stethoscope and simultaneously observe the sphygmomanometer. The first knocking sound, card cough, is the subject's systolic pressure. When the knocking sound disappears, that is the diastolic pressure. Record the patient's location, method, and position. Next is taking the patient's pulse rate and oxygen saturation using the pulse oximeter. A clip-like device will be placed on the patient's finger. The patient may feel a small amount of pressure, but there is no pain or pinching. Keep the device on for as long as needed to monitor the patient's pulse and oxygen saturation. Once the test is over, the clip will be removed. In assessing the patient's balance and tolerance, we use the Berg Balance Scale. It is a 14-item list, with each item consisting of a 5-point ordinal scale ranging from 0 to 4, with 0 indicating the lowest level of function and 4 the highest level of function, and takes approximately 20 minutes to complete. Sitting unsupported. From sitting to a standing position. From standing to a sitting position. Next is transfers. Standing unsupported for 2 minutes. Standing with eyes closed for 10 seconds. Standing with feet together for a whole minute. Tandem standing for 30 seconds. Standing on one leg for 10 seconds. Turning the trunk with feet fixed. Next is retrieving objects from the floor. Turning 360 degrees. Lastly is reaching forward while standing. For the range of motion for the hip flexion, the normal ROM is 0 to 120 degrees. The position of the patient is in supine and knees extended. Therapist stabilizes the pelvis to prevent posterior tilting or rotation. The fulcrum is placed on the lateral aspect of the hip joint, greater trochanter, and the proximal arm is on the lateral midline of the pelvis, and the distal arm is on the lateral midline of the femur or the lateral epicondyle. For hip abduction, the normal ROM is 0 to 40 degrees. The position of the patient is supine, knees extended. The therapist stabilizes the pelvis to prevent lateral tilting. The fulcrum is placed on the ACEs. The proximal arm is on the imaginary line between two ACEs, and the distal arm is on the anterior midline of the femur. For the hip extension, the normal ROM is 0 to 20 degrees. The position of the patient is prone and knees extended. The therapist stabilizes the pelvis to prevent anterior tilting. The fulcrum is placed in the lateral aspect of the hip joint, greater trochanter, and the proximal arm is on the lateral midline of pelvis, and the distal arm is on the lateral midline of femur or the lateral epicondyle. The hip external rotation and internal rotation, the normal ROM is 0 to 45 degrees. Position of the patient is sitting, knees flexed 90 degrees on the edge. The stabilization of the therapist is on the distal femur to prevent abduction or adduction. The fulcrum is placed on the anterior aspect of the patella. Proximal arm is perpendicular to the floor, and the distal arm is on the anterior midline of the lower leg. For the manual muscle testing of hip flexion, grade 3, patient completes test range and holds the position without resistance. For grade 2, patient completes the range of motion in a side-lying position. For hip flexion, abduction, and external rotation with knee flexion, grade 3, patient completes movement and holds position but takes no resistance. For grade 2, Patient completes desired movement. For hip extension, grade 3, patient completes range and holds the position without resistance. For grade 2, patient completes range of extension motion in a side-lying position. For hip abduction, grade 3, patient completes available range of motion in a side-lying position and holds end position but takes no resistance. For grade 2, patient completes available range of motion in a supine position. For hip internal rotation, grade 3, patient holds end position but takes no resistance. For grade 2, patient completes the range of motion as the hip rolls inward past the midline. Minimal resistance can be offered to offset the assistance of gravity. For hip external rotation, grade 3, patient holds end position but tolerates no resistance. For grade 2, patient completes external rotation range of motion as the hip rolls past the midline. Minimal resistance can be offered to offset the assistance of gravity. And patient position is in supine.
Knapp-Ziegler test. The patient is seated and the examiner stands behind the patient with his or her fingers over the patient's jugular veins. The examiner compresses the veins for 30 seconds and then asks the patient to cough. The presence of pain may indicate a nerve root problem or space-occupying lesion.
Valsalva Test. The examiner asks the patient to take a deep breath and hold it while bearing down as if moving the bowels. The presence of increased pain may indicate a space-occupying lesion.
SLR1 test. Position the patient in supine. Have the hips in flexed and adducted position with the knee in extension and the ankle in dorsiflexion. Positive result would indicate sciatic and tibial nerve affectation.
90-90 straight leg raising test. The supine patient flexes both hips and knees to 90 degrees. Then, ask the patient to actively extend each knee in turn as much as possible. A positive test is the inability to fully extend the knees, which would indicate tight hamstrings.
Milgram's test. The patient lies supine and actively lifts both legs off the examining table 5 to 10 centimeters. Ask the patient to hold the position for 30 seconds. If the patient is unable to hold the position, it would indicate positive joint dysfunction. Patrick's test or the figure 4 test. The patient lies supine and the examiner places the patient's test leg so that the foot of the test leg is on top of the knee of the opposite leg. The examiner then slowly lowers the knee of the test leg towards the examining table. A positive test is indicated by the test leg's knee remaining above the opposite straight leg, which would indicate a possible hip affectation.
Koenig's test. The patient is supine with the hands cupped behind the head. The patient is then instructed to flex the head onto the chest and raise the extended leg actively by flexing the hip until pain is felt. Then, the patient flexes the knee, and if the pain disappears, it is considered to be a positive test, which would indicate meningeal irritation, nerve root involvement, or dural irritation. Kemp's test. The patient stands with the examiner standing behind. The patient extends the spine while the examiner controls the movement by holding the patient's shoulder. A positive sign would be pain, numbness, or tingling in the area of the back or the lower extremities on the side being tested, which would indicate nerve root irritation.
Bowstring test. The PT carries out a straight leg raising test and pain results. While maintaining the thigh in the same position, the PT flexes the knee slightly to reduce the symptoms. Thumb or finger pressure is then applied to the popliteal area to re-establish the painful radicular symptoms. This test would indicate tension or pressure on the sciatic nerve and is a modification of the straight leg raising test.
Okay, sir. Good afternoon. May gabi, sir. Ako din mong PT karon. So karon, tudloan di ka og exercise. Sa atong buhaton, palihog lang kog, sir. Kog lang ta. Okay ra, sir. Wala na kayo pamati.
Ay, wala.
Sige, sir. I-relax lang sa ta, sir. Karon, sir, akong ganahan buhaton nimo kay tukod lang kasi mong elbow, duha ka elbow, sir. Sige daw, sir, tukod daw. Na, unya, extend lang tagamay, inat lang tagamay niya. Maintain lang ang kanimong lower back flat sa floor, sir, ha. So, relax sa ta, sir. So, ato to siya i-maintain for 15 seconds. So, count with me lang, sir, ha? So, ready na ka, sir?
Hindi na.
Okay, sige. 1, 2, 3. Sige, sir. Yes, yeah. 1, 2, 3. Count lang, sir. Dili na sakit?
6.
15. Sige, go. Relax na po, sir. At then, buhat, kanapo na to balik-balik po sir. Sige, again na sad sir. Isa sir. Okay, 1,
2, 3,
4, dili ra sakit sir. 15, very good. So, relax na sad sir. Marami. Sige sir. So, umana ta sa first sir no. So, ang ikaduha na punta sir. Karon sir, mas taas-taas na siya sir. Mackenzie number 4. So, kani siya sir, kung ganiha sir, gamit tukod sa imong elbow, karon imo straight ta ng imong elbow sir. So, straight lang imong elbow sir ha. Sige. So, 15 seconds gihapon ang hold ani sir. Ato siya i-maintain for 15 seconds and then kanapo gyapon balikon. Okay, sige, ready na ka sir? Count with me gihapon sir ha. Maintain lang gyapon imong kanang kuan sama flat sa floor. Sige. 1, 2, 3. Sige, starting position na sa sir para masayon-sayon. And then, straighten na itong elbow. Lift your body lang, upper body. Then, count with me sir. 1, 2, 3, 15. Sige, relax sir. And then, ready na ka mo balik sir?
Ready na.
Sige, balik na sad sir. Isa na po balik sir. Okay, count na sad sir.
1,
count lang.
2,
Dili na sakit sir.
3, 4, dili. 5, 6, 7, 8,
15. Sige. Okay, very good. Hi ma'am, today mag-perform ta og pelvic exercise tilt, posterior pelvic tilt. Para na siya sa mong deep core muscles ato i-activate. So sayo na siya ma'am. Ang first mo buhaton kay mo itong pelvis no. So atong first buhaton kay i-draw ni mo imong belly in, or stomach in baron. While maintain ka og kanang flat back sa kuan lang sa floor. Dapat make sure nga flat imong back sa floor. So i-tilt lang imong pelvis while belly in ka. Okay? Sige, practice ata ma'am. You 1, 2, 3. You try daw. Tilt. And then relax. And then tilt na sad. And then relax. So, i-maintain na to ang tilting ma'am for 6 seconds hold. Hold na to siya for 6 seconds. Okay? So, let's start na ma'am ha. Sige, 1, 2, 3. Count with me ma'am. Inig-hold ni mo. 1, 2, 3. Tilt ma'am. 1, 2, 3, 6. Sige, relax. And then again na sad ma'am. Sige, tilt. 1, 2, 3, 4, 6. You relax. Dili ra sakit, ma'am? Okay, very good.
Single leg sitting on unstable surface. In this technique, you will instruct the patient to sit on an unstable surface and hold it for 6 seconds times 3 sets. So this technique will improve the dynamic stability of the patient. PNF stretching towards D2 flexion and D2 extension. This technique will improve the patient's posture. For D2 flexion component, you will instruct the patient to open your hand and lift your arm up and out. For D2 extension component, you will instruct the patient to squeeze my fingers, pull down and across your chest.
These are resistance exercises using TheraBand for 6 reps times 3 sets. Attach an elastic band to a secure object. Loop the band around the ankle and stand facing away from pull. Then extend the leg forward, keeping the knee straight. Slowly return to starting position. For hip extension, attach elastic band to a secure object. Then loop the band around the ankle. Stand facing away from the pull and extend the leg backward, keeping the knee straight, and slowly return to starting position. For hip abduction, attach elastic band to secure the object, then stand with involved leg away, keeping the knee straight and pull away, moving the leg outward, then slowly return to starting position. For hip adduction, attach elastic band to secure object at ankle level, then stand with involved leg towards the pull. Then keep knee straight and pull the leg inward. Slowly return to starting position. Place elastic band under the feet and hold in hands and keep the elbows straight. Stand with feet and shoulders distance apart, then slowly bend the knees to 45 degrees and return to standing position.
For hot packs, we should instruct the patient to lie on her stomach, and the PT should put a draping on the patient before applying the hot moist pack. The PT will put the hot packs on the right lower back and for the right thigh for 20 minutes for pain relief. To increase lower extremity strength, we are going to let the patient sit and instruct the patient to raise her foot upwards for 15 reps times 2 sets. To stretch the pectoralis minor, we are going to instruct the patient to put both arms on the doorway and put the other leg forward to administer a stretch on your shoulders. Instruct the patient to hold it for 6 seconds. Do this for 3 sets to improve the patient's posture.
For another home exercise program, you could let your patient perform dance aerobics for 30 minutes to maintain muscle endurance at home. Self PNF towards bilateral D2 flexion, 6 seconds hold times 3 sets times 10 reps to maintain posture.
For the warm-up, stepping, forward walking, and lateral walking with both arms raised overhead and lowering it down for 5 minutes.
So, we try to tip